So first of all, I'd like to thank everybody who brought in canned food donations. You know those generous donations are through the United Way, going to be used for the Hunger Coalition and will be put in our food pantries. And so we thank you for bringing those donations in tonight. I want to introduce Emily Steve from the United Way of Inner Wisconsin, and she will say a few words about how those canned goods get used.
Hi, Emily.
Good evening, everyone. This year marks the 6th year of United Way of Inner Wisconsin's Hunger Coalition United We Can event. This is a food sculpture contest that takes place out at Whitterfield, and this year's event will be taking place this Thursday, actually, the June 7th. Combating hunger and creating awareness around our community's food insecurities are the goals of this annual event. Since 2013, this annual event has had 47 sculptures created and 32,000 pounds of food collected and distributed to food programs around our community. This year we will have 12 teams comprised of local businesses and organizations that will be putting their creativity to the test. Judges will select the most creative and most nutritious sculptures, and fans who come in will be able to select their favorite Major League and minor league teams. Major league teams are going to be building with over 500 items, and minor league teams will be building with under 500. Thank you for your support this evening. I was trying to do a quick tally. We have almost 200 items that were donated from you alone this evening, so thank you very much. That food is going to be taken over to Whitterfield, and we actually have a team that will be building a live sculpture that evening, and so on behalf of them, they thank you very much for that. And thank you so much for all the food then from this event will be distributed to 6 local food programs here in our community. So thank you very much for helping United Way strike out hunger in our community. Have a great evening.
I just want you to know that Aspirus Riverview has been in this contest for 5 years running. The last couple of years we have not taken home a trophy, much to our deep regret. And so this year, if you want to show up in the afternoon, you don't have to buy a ticket, and get a little ticket to put in our bucket, of course. It would be much appreciated. We have our canned sculpture up in our lobby right now. He doesn't look quite right. It's a SpongeBob, and unfortunately, the cans that were supposed to come in of corn that were yellow came in and had blue labels, so he looks like he's really out of breath or the water's really cold. But we do have yellow cans for the can sculpture tomorrow. So our topic tonight is called AFib, or Keep the Beat. And this is really a common condition that affects millions of people. Untreated, it can lead to a stroke, heart failure, or even death. Symptoms can stop you from being active and doing the things that you love. Common symptoms are heart palpitations or feeling this fluttering in your chest, racing, irregular heartbeat, shortness of breath, dizziness or fainting, lack of energy or fatigue. Because one of these symptoms of AFib is irregular heartbeat, we thought it would be fun to have a little refresher on how to take your pulse. Do you all know how to take your pulse? Well, I thought I did, but I did learn something new from this. So we most commonly check our pulse in our wrist or our neck, correct? So on your wrist, I've never been able to get my pulse, and I'm always fascinated that they take the pulse on my neck, on my wrist, and tell me what it is. It's always because I have placed my fingers here, but you're supposed to place 2 fingers under your thumb on your wrist. And if I do that, I actually do have a pulse, which is a good thing. I was a little worried there for a while. The other common place is to apply pressure on your neck. And not a lot of pressure, ladies, just a slight pressure. Thank you. I don't want anybody passing out here. Although we do have 2 doctors in the house. So let's take a test. Let's have everybody find their pulse. Tammy will give me 15 seconds.
Try, she looks her fingers.
Okay. She's trying. She's got to get her stopwatch going.
Okay, does everybody find their pulse? Okay, I'll tell you when to start counting. We're going to count for 15 seconds. Ready, Go.
Go.
Stop.
Okay, so normal heart rate is anywhere between 60 and 100 beats per minute. But that being said, if you're an athlete, you could have a heartbeat down to 40 beats per minute. I remember one time my husband's pretty athletic, and when he was getting his wisdom teeth out as an adult, they had him back on this chair, and his pulse kept dropping, and his blood pressure kept dropping, and they kept sitting him up. So sometimes maybe it's not great to have those things. No, I'm kidding. But my pulse rate was about 70, so that's normal, and that's what you should look for.
That's per minute, so you multiply by 4.
Yes, you multiply by 4.
Multiply by 4.
Sorry. Thank you, Jim. Really, my heartbeat was about 15. No. So now I'd like to introduce our 2 speakers for tonight. We're very lucky to have Dr. John Jonkowski, wave your hand, and Dr. Kevin Rist here. Both have clinics up in Wausau, but also practice here in Rapids. And so we are so happy that they could come down and talk to us tonight. Their presentation is really great. I have seen it before, and I think you will enjoy not only the pictures, but some of the videos that they will show you. So Dr. John Jonkowski is a cardiac surgeon and co-director of the Atrial Fib Clinic for Aspirus Heart and Vascular. He earned his medical degree from the University of Michigan Medical School. Go Blue! Sorry, we are in Buckeye country. I mean Bucky, not Buckeye. And completed his residency at State University of New York at Buffalo. He completed his fellowship at the University of Washington in Seattle. Dr. Jonkowski takes a special interest in lung disease, minimally invasive surgeries for valve disease, TAVR, a specialized heart valve replacement procedure, and of course, AFib. He enjoys sailing, kayaking, camping, cooking, and gardening. Very well-rounded. Dr. Kevin Rist is an MD and a PhD, and he's a cardiologist with Aspirus Heart and Vascular and specializes in cardiac, electrophysiology, and cardiovascular disease. He also serves as assistant professor of medicine for the University of Pittsburgh. I'm not sure how you do that. Do you do that through like video conferencing, or do you fly to Pittsburgh? Yes, he says. Dr. Rist earned a Doctor of Medicine degree as well as a Doctor of Philosophy degree in respiratory physiology from Dartmouth Medical School in Hanover, New Hampshire. He specializes in treating heart arrhythmias using ablation techniques, devices such as pacemakers, implantable defibrillators, I can say it, and drug therapies. Outside of work, Dr. Rist enjoys family activities, ski racing, watching or participating?
Both.
Yes, he says. Hockey and hiking. Now, I have heard from an inside source that both of these gentlemen have very dry senses of humor, and so I am challenging them tonight to share that with our ladies. Without further ado, let me introduce Dr. John Jonkowski.
Hello. All right, well, thank you all for coming out tonight. It's a beautiful evening, like she said, and it's a little hard to be inside. So the general layout of these evenings is we spend about 30 to 45 minutes giving the presentation, and then we'll have about 30 to 45 minutes to answer questions. We understand everybody in the room doesn't have AFib like a lot of our talks, but there's a lot of you, so I'm counting on lots of questions. So maybe, can we turn down?
Oh, yes.
The videos will show up better.
Oh, nice.
That's better. So hopefully you can all see that. This is, and if you can't hear me, let me know, but this is a pretty good mic, so I think even in the back. Here's your heart. On the left, your heart in normal rhythm. So the top two chambers, the atria, contract, and they help fill the bottom two chambers, the ventricles, and then the ventricles pump the blood either to your body or to your lungs. On the right here is a heart in atrial fibrillation. The top two chambers are now they're no longer contracting, they're fibrillating or quivering. The bottom two chambers still pump, but they're not getting the benefit of that pre-pump function of the upper chambers. And so your heart function goes down by about 15 to 20% the minute you go into atrial fibrillation. So this is one way to look at a normal heart and a heart in atrial fibrillation. Here's another way to look at it. This is an electrical kind of diagram of how this works. So you have a couple of electrical centers in the heart. You have your SA node that sends out an impulse to the atrium, and you have an AB node down here that sends out an impulse to the ventricles. And when this is all working like it should, everything contracts in sort of a rhythmic, systematic function. When your heart's in atrial fibrillation, you can see that this isn't quite right. So you've got a lot of extra chaotic electrical activity going on in the upper chambers. So they're not contracting, they're sort of just quivering because there's so many confusing electrical signals bouncing around. The AB node still gets activated and it still sends the impulse to the ventricles. But you can see, I think this is actually sometimes a better way to understand the difference between normal sinus rhythm and atrial fibrillation. A couple of definitions to get out of the way early on here. Atrial fibrillation can be paroxysmal, or we call it paroxysmal, you might call it intermittent, or it can be persistent. And paroxysmal is AFib where your heart goes in and out of rhythm maybe a couple of times a day or a couple of times a week. The key is that it goes back into rhythm on its own. Persistent atrial fibrillation is either AFib that lasts more than a week, which doesn't really count as going in and out, or you always have to have a defibrillation. So we shock your heart back into rhythm, or you get medications to get your heart back into rhythm. Long-standing persistent AFib is just AFib that's been there for more than a year. Atrial fibrillation is fairly common. There's about 2.5 million people in this country with AFib. That's about 160,000 new cases every year. The basic rule of thumb is that it doubles with each decade of life. So it's more common in 50-year-olds than it is in 40-year-olds. It's twice as common in 60-year-olds as in 50-year-olds. This is another way to look at it. If you're pretty young, if you're less than 55, you have about a 1 in 1,000 chance of having AFib. As we walk up through the decades here, if you're older than 85, you got a 1 in 10 chance of having AFib. So AFib is very age dependent. It's just one of the many ways in which our heart reflects its age. Atrial fibrillation consumes a fair bit of medical resources. About 350 hospitalizations, 5 million office visits, roughly 250,000 ER outpatient visits, $26 billion a year in the US alone for AFib. So when you go to the CMS statistics, CMS is Medicare, they calculate that it costs almost $9,000 a year more to take care of an older person, somebody on Medicare who has AFib versus somebody who doesn't have AFib. Atrial fibrillation tends to come with some other cardiovascular diseases. So about 70% of people with AFib have high blood pressure, valve disease, coronary disease. What this also means is about 30% of people with AFib don't have any of that. We sort of loosely call that lone AFib. And so that's where a great deal of resources have been invested in the last 10 years, is in trying to treat people with either catheter therapies or surgical therapies, minimally invasive surgical therapies, which we'll talk about, who don't, for example, if you come and see me and you need your mitral valve repaired, it's pretty easy for me to say, well, I'll fix your mitral valve and I'll do your procedure for AFib while we're in there. But if you have AFib and it's bugging you and you're not doing well with medications, but you don't have any other reason to have open heart surgery, is there some way that we can help you with a minimally invasive surgery? And so that's where a lot of effort has gone in the last 10 years. Atrial fibrillation can also have a significant impact on your quality of life. So as practitioners, we have these standardized form questionnaires. We call them SF-36s, and it's a whole raft of questions. Some of you have probably been subjected to this over the years. And the questions can be divided into questions that ask about general health, physical functioning, mental health, or social functioning. So what they did was they gave the same questionnaire to people who have AFib, to people who have congestive heart failure, to people who have had a heart attack, and finally the healthy patients. What they found, you might expect that people with AFib have a lower quality of life or a worse quality of life than people in yellow who are healthy. But what they found was that not only is that true, but people with AFib have a worse quality of life than people with heart failure or people who have had a heart attack. So what that tells us, that kind of confirms in a very objective fashion the fact that AFib really can have a significant negative impact on your quality of life. Unfortunately, atrial fibrillation also comes with some very real complications. So if you have atrial fibrillation, you're 3 times as likely to have heart failure, you're 5 times as likely to have a stroke, you're 2.5 times as likely to have a heart attack, and you're twice as likely to die as compared to someone in your age group who doesn't have atrial fibrillation. So how do we treat AFib? Well, as with a lot of medical problems, diseases, we start with medication. So the first thing we want to do is we want to thin your blood. We put you on an anticoagulant. In the old days, that was Coumadin or warfarin, and nowadays we have several options. We have Xarelto and Pradaxa and Eliquis. We do that so that you don't have a stroke. Now, we can't completely reduce your chance of having a stroke to 0, but we can reduce it by about 60% by being on a blood thinner. We will often do a cardioversion. If you come in the emergency room with a heart rate, so you all just figured out how to check your heart rate, right? So if your heart rate's 150, you come in the ER because you're not feeling good, you're feeling these palpitations, and your blood pressure is 80, that's not very good. That means you're probably going to get kind of a semi-urgent cardioversion to get you back into rhythm. That doesn't happen every time you come in the ER, but that is one way of getting you back into rhythm, and it's one way of treating AFib, at least emergently. The other reason we do a cardioversion is sometimes, myself or Dr. Rist or Dr. McKitsy will see a patient in the clinic, in the AFib clinic, and we're having a hard time sorting out, does this patient really have symptoms? Because sometimes people who've been in AFib for 2 or 3 years, they've gotten so used to it they can't tell. And so sometimes what we resort to is we make sure they're on a blood thinner for at least a month before, and we do a cardioversion. And if they go home and they feel great for a couple of weeks, and then they don't feel great anymore, and they can tell you the day that they stop feeling not great, and they come back and they're back in AFib, then you can get a sense that they probably do feel better in normal sinus rhythm. Whereas if you know you got them into rhythm and they come back 2 weeks later and they're back in AFib, they never really felt any different, and they can't tell you the day they stopped, they didn't really notice anything, then you look at that and say, well, I might treat their AFib, but it's probably not going to be for symptoms. When we talk about rate control versus rhythm maintenance, what that means is that sometimes we just try to get your heart rate down. So your heart has more time to fill, it can pump better, you can have a good blood pressure, and you don't have so much in the way of symptoms. So that's rate control. Whereas rhythm maintenance is we actually get your heart back into rhythm, usually with a cardioversion or with medical therapy, and then we try our best to keep it in rhythm. And so that's a big difference between management strategies. If all that works, that's fantastic, and that probably works for more than 95% of people with AFib. But if it's not working, and we'll talk about some of the reasons how we know it's not working, then we have lots of things that we can do. So Dr. Rist or Dr. McKitsy can do a catheter-based ablation. They can ablate rhythms on the right side or left side of the heart, and he'll tell you a little bit more about that. They can actually ablate that AV node, that little center you saw in the middle of the heart, and give you a permanent pacemaker so that you have better rate control and you feel better. Surgically, we can do things like a minimally invasive maze, and I'll show you a little video of that. We can do a full maze, which is essentially open heart surgery. We can get rid of the left atrial appendage. Finally, at the very end, we'll talk about hybrid therapy, which is where we combine some of the minimally invasive things that we do in the OR with a catheter ablation to give you a very good result with regards to staying in rhythm. So here's the difference between being an AFib and not having a good heart rate. So here's your heart in AFib, you got a heart rate in the 120s, you're probably not feeling so great. We get you on some medications, you're still in AFib, but now your heart rate's slower, your heart has more time to fill, you've got a better blood pressure, and now we've actually either done a cardioversion or got you back into rhythm, and now your heart's back into rhythm like it should be. So that's the difference between atrial fibrillation with rapid heart rate, atrial fibrillation with rate control, and being back in rhythm. Here's how strokes happen. You have a little part of your heart called left atrial appendage. You can form a clot in there. That clot gets dislodged, goes through the atrium, the ventricle, out into the aorta, and up into the blood vessels that go to the head. When that clot arrives in your brain, you've just had a stroke. And so that's why you need to be on a blood thinner. That's a very important part of treatment for atrial fibrillation. So here's some of the reasons that we might treat atrial fibrillation surgically. And I would actually add, we would treat it either interventionally or surgically. If you have, the meds aren't working, you're continuing to have symptoms, you don't feel good, maybe you've been on one med or even two meds and they're just not keeping you in rhythm or keeping your rate well controlled. Sometimes the med work, but you feel so crummy being on some of these medications that it's great to be in rhythm or it's great to have rate control, but now you don't have energy, you're always short of breath, you're always tired. And so we would call that medication intolerance rather than medication failure. If you can't be on a blood thinner, we've talked a couple of times about how important it is to prevent a stroke by being on a blood thinner. Say you have blood in your stool, you have blood in your urine, you've had a bleed into your brain, that would pretty much knock you out of the running for safely being on a blood thinner, and so that would be a reason to treat your atrial fibrillation. If you've been on a blood thinner and you are ostensibly doing okay, your blood thinner level is good, or you're taking your other pills that you don't need to monitor and everything seems great, and then you come in with a stroke, well, that is definitely a failure of anticoagulation. So that is someone who we would strongly consider doing something for. If you've had a catheter ablation that maybe worked initially and then failed, we might think about another catheter ablation, or we might think about surgery. If you're having heart surgery, we talked about this a little bit, if you're already having heart surgery, we would certainly do something with your AFib at the time of that open heart surgery. And finally, sometimes we meet people and we lay out all the options. They say, you know what, I know medications are kind of easy, but I'm 50 and I really don't want to be on all this for the rest of my life. Can't we do something a little bit more invasive? And the answer to that is certainly a yes. So Dr. Rist is going to tell us a little bit about catheter ablation.
So good evening. Thank you for having us here. I did want to mention one thing. We have my partner for many years here, Dr. McKitsy, so he's an electrophysiologist, and some of you may have seen him on occasion. We're getting a third partner, Dr. Ortiz, and he will be spending 2 days a month at the Riverview Hospital. So he'll be spending a fair amount of time down here, and that will make it easier for you to be evaluated for electrophysiologic problems, including AFib. So catheter ablation for atrial fibrillation and many other arrhythmias is very much like a heart catheterization that some of you may have had, or you've had family members or friends. But when we do a catheter ablation or catheter-based procedure for rhythm problems, we generally have to get inside the heart. And most people are having heart catheterizations for coronary disease, where you go through the arteries and you get back, you work your way upstream as the blood's being pumped out of the heart, and you inject dye into the arteries on the outside of the heart. But the electrical, most of the wiring, the electrical system is mostly inside the heart. So our approach when we're doing a catheter-based ablation is to go into the veins. And we go into the veins of the leg. They go up to the heart through what's called the inferior vena cava, and we can put in 2, 3, 4 different catheters. In this case, we're not using catheters to inject dye. We're using catheters which are really steerable wires, because we're trying to measure the electrical activity of the heart. So the approach for catheter-based ablation for AFib generally requires that you stay overnight. The procedures, they can take occasionally 3 hours, but generally 4 or 5. They're done under general anesthesia. So you're unaware of anything during the procedure. You have to lie relatively flat for about 3 hours afterwards, and you go home most generally the next day. Your activity is restricted no more than a week, even if you work in the paper mill here or sawmill or any other very high physical activity. So you can recover from it quickly. As Dr. John Koski has pointed out, atrial fibrillation is a very chaotic rhythm. And when we try to analyze it, we actually find that it's made up of lots of rhythms. There are point sources, and with my my helpful audiovisual aids assistant here, if we're lucky, we will. John, I don't think you were in the AV club, were you? But I was. Until the day that I ripped a screen because I was too short to pull it down. then I wasn't. But, so I'm glad I'm not trying to fix that equipment. Anyway, so atrial fibrillation looks like chaos, but it's really made up of point sources like little flashing lights, up on Granite Peak that radiate the electrical activity out on their own frequency, and other types of rhythms where the rhythm is actually traversing around different chambers or around obstacles like the valves and going in a circular fashion, but at a constant rate. And then on top of that, you've got all this tissue, which we call the substrate, which has which conducts variably at different rates. So you get all that sort of flashing light thing that, thank you very much. So I'll be showing you examples of that in a minute. So when we said femoral access, overnight stay, we're talking about going in the veins of the leg. People return to work in a week or less. Now we can use radio frequency energy to blot out some of these point sources and corral some of these bad behaving spots in the heart. Or we can use a cryoballoon, which is a way of freezing the muscle that's causing problems. Now specifically for atrial fibrillation, the French determined a while back that most AFib starts in the veins as they come into the back wall of the left atrium, the veins that come from the lungs carrying the oxygen-rich blood. And so to do a good job in atrial fibrillation, you have to what we call isolate those veins. Now we're not preventing the blood from flowing through it, we're just putting a region of scar around those veins so the abnormal electrical activity in the veins can't get out into the left atrium and create havoc. So if you think of AFib as a sort of a mob action on the mall, you can think of the pulmonary veins as where the little bomb throwers sit out in the alley and throw something in to get it started. So if we don't allow them to throw bombs from the alley, then we don't get this big mob action started. With paroxysmal AFib, or that intermittent AFib that Dr. Jankowski talked about, our success rate is about 80% at 1 year. So that doesn't sound great. It's like, well, why can't we cure it forever? Well, atrial fibrillation is sort of a progressive problem. I mean, the things that get you into AFib are most primarily age, unfortunately, which is something you want to have and you want to keep having, but it takes a toll on the atrium. But there's other things, as Dr. Jankowski discussed: valve disease, coronary disease, high blood pressure, maybe sometimes thyroid disease, which of course we can fix. So so it's not surprising that we can't fix it all the time forever, but we can often treat it very effectively with surgical ablation techniques or catheter-based ablation techniques. 30 years ago when I went to medical school, there was no thought that anybody could ever fix AFib at all. And so what's gone on in the last 10 years has really been remarkable. Now, some of our patients will remain on rhythm control medications. For example, if you have you start with somebody who's in persistent AFib and you end up with intermittent AFib, that generally people feel better, and then you give them a medicine and maybe they stay out of AFib, for 2 years. I mean, medicines are effective when added on ablation. Some patients may remain on anticoagulation. If we don't feel like we have an ablation that is going to hold on to sinus rhythm for a long period of time, we, one, monitor it with a little thing called a loop recorder that gets implanted under the skin. And if people are having lots of AFib, then we would probably want to keep them on anticoagulation. If they're not, then we could approach it as, you know, if you start having a lot of AFib, then we'll put you back on anticoagulation. This depends a little bit on what everybody's risk factors are. It's not totally guideline directed, so it's where, you know, a physician and the patient sort of get together to figure out what's going to be best for them. And Dr. Jankowski will describe a device where that left atrial appendage that he said, you know, forms a lot of the clots that we worry about, where that can be closed surgically from the outside of the heart. And in some individuals, we can plug a thing in that left atrial appendage called the Watchman. And, you know, this is relatively new for about the last 2 years. We've done about 30 patients, and they do pretty well, really. And the concept there is that, again, it will not prevent all clots, from, all people from all episodes of stroke, but it'll reduce it as much as being on anticoagulation. Now, for the 65 and older population, of course, our medical care is determined, you know, fair amount by the government, and right now you have to have 3 risk factors. I won't go into that, but you have to have 3 risk factors, and you have to have a reason you can take Coumadin. You're bleeding frequently, you're falling down, you're unstable to be on a blood thinner, you have certain types of troubles with blood thinners, so, you know, or say if you were in an occupation where you shouldn't be on a blood thinner, most of the time that doesn't come up with a 65 and older population, but that's what the government wants at this point to underwrite that. So this is going to be an example of the cryo balloon. You're going to see a catheter coming up from the patient's leg, going into the heart, crossing over between the right and left atrium, and then putting a thin little wire in one of these veins that is allowing the oxygenated blood to come back into the left atrium. And over that is going to be advanced a balloon. The balloon is filled up with actually nitrous oxide as a liquid, and as it forms a gas, it cools off all the surrounding tissue that you press it against. So the artist got little lightning in there that's supposed to say this malfunctioning electrical activity. That is supposed to demonstrate the contrast that we shoot into the vein to demonstrate that we've snugged up the balloon enough. And then as the temperature drops, you get a donut-shaped ring of cryoablated tissue, which is, of course, you know, a frostbite scar. And that's been found to be a very effective way of isolating those veins and reducing the amount of AFib that gets injected into the rest of the left and right atria. Without that approach, you would be doing little dots with a radiofrequency catheter, getting all the dots to line up together. And we do procedures that way also, but this is a very nice way to go. Now, this is an example of these point sources that I talked about that fire and can either start AFib, or as we get rid of some of the AFib, we find these things that can initiate it again. This is the right atrium in a patient. That little thing with the stuff sweeping out is the electrical activity coming from that point. That's a catheter in 2 different views that is going to ablate that point. By that, in this case, the catheter is heating that tissue up so it won't fire like it was anymore, and the symptoms of palpitations and the other things that go along with arrhythmias and AFib go away. The next example I show you is again of a right atrium. This is the inferior vena cava where the catheters come up from the leg. These little things here indicate the catheters with the different electrodes on it to help us know what we're going. This is done as a map for every single patient that we work on. For AFib, we would be working on it both in the right atrium and the left atrium. This is just a view from 2 different sides of the right atrium. This is where the tricuspid valve would be, this round thing. And what I'm going to be showing you is a rhythm called flutter, Remember I said that AFib can be made up of point sources, it can be made up of these things that go in a circle, in this case that's called a flutter, and there's going to be a flutter in the next picture that goes around here. So the electrical activity, instead of coming up from up here normally and sweeping down, is going around and around the atrium just like it would go around a barrel. And that also requires anticoagulation. Atrial flutter is often seen in people who have AFib, and people can switch back and forth between those rhythms. Atrial flutter still causes your heart to go too fast, still requires anticoagulation, but the nice thing about it is most of the time it's very ablatable. If we just put a scar from this point down here, which I'm going to show you on the next 2 slides, then that rhythm can't go in a circle anymore. The scars are sort of like putting in a fire line when you're fighting a forest fire. If the scar is broad enough, then the electrical activity can't propagate. So here's one of the people with a different person who has a flutter rhythm, and that's the electrical activity going around and around that we pick up in our lab in this person. This direction up here is going toward the left atrium. These little dots are where we ended up putting our ablations so this rhythm wouldn't occur anymore. And you know, that we're 95% successful at that forever. That's a very successful rhythm to get rid of because we have very specific places we can treat that. Here's another example of atrial flutter. And these little dots are where we put our ablations, and again, that took care of that. This is a way of modeling the patient's insides of their heart. It's done by putting electrodes in many places on the chest. So there's a lot of stick-ons that you know, people like when they're really young. I think our nurses get very tired of it, but the way that works is that we put stick-ons between the right and left sides of the chest, front and back, top to bottom, in addition to all the EKG electrodes. And we pass a current through the body in 3 dimensions. And then the electrodes in there pick up that current, and a computer generates a picture like these pictures while in real time. And that way we don't have to use as much X-ray, and it's actually much more accurate. So it's a very good system, and it's evolving, and it's a great part of technology to help our patients and to help us do a good job.
All right, we are going to talk about surgery for atrial fibrillation. So we can do this through an open sternotomy incision. That's what we typically think of as open heart surgery. We can do this minimally invasively. So think 3 small, about 1-inch incisions on each side of your chest. We go in, we push the lung aside, and then we open up the sacra on the heart, and we create lines of scar on the outside of the heart. We can use radiofrequency to heat the tissue. We can use a cryoprobe to freeze the tissue. Again, the design here, the goal here is to create a line of scar. Scar acts as sort of a firewall. An electrical impulse can't get through a line of scar. The autonomic nervous system, the part of our nervous system that reminds our body to breathe, reminds our heart to beat, keeps the things working on our tummy, that part of the nervous system regulates your heartbeat, and those things are found on the outside of the heart. So there's a unique advantage to working on the outside of the heart, whether it's done minimally invasively or through a big incision. We can check some of these lines. We don't have quite the degree of finesse that they do in the cath lab with regards to looking at some of these lines and studying conduction times, but there's some very easy ways to check that what we've done is actually what we said we set out to do. Finally, part of any surgical ablation for atrial fibrillation is getting rid of the left atrial appendage. Some of the advantages of doing this minimally invasively is that there's no heart-lung machine. Some of the complications and some of the bad things that happen in heart surgery are because of the heart-lung machine that we need to use to support your body while we have your heart stopped. If we're not stopping your heart, we don't need that part of the procedure. A minimally invasive maze does not require blood thinners. In fact, we don't want you to be on blood thinners when we do this. It's a lot less invasively, it's a lot less invasive, and what that really means, so a lot of the risks are still the same, but the recovery is like night and day compared to open heart surgery. It's a short procedure, usually takes 2 to 3 hours, and almost everybody goes home the next day. So here's the back side of your heart. The big blood vessels coming out the top of your heart are the aorta, which is going to deliver the blood supply to your body. The pulmonary arteries, which are going to deliver the blood supply to your lungs. The veins that you see here, the blue structures, are the veins that bring the blood back to your heart from the upper part of your body and the lower part of your body. And finally, this is your left atrium. This is the part of your heart that sits basically against your food tube and against your spine. And these are the veins that are going to deliver the blood back to the left atrium from the lungs. So picture your right lung out here and your left lung out here. This is where all the action is with AFib. So whether we're working on the outside of the heart or the inside of the heart, what we're really going after is the veins where they meet up with your atrium. So we want to prevent an electrical impulse from out here getting to here. So how do we do that? Well, we create a line of scar. And that can be done, like Dr. Risch showed you, that can be done with a balloon or a catheter inside the veins, or it can be done with a clamp on the outside of the veins. So we'll do that on both sides. So now you've got a line of scar around this set of veins, that set of veins. This is a little bit older slide. So in the old days, we just made one connecting lesion. Now we actually make a connecting lesion across the top and across the bottom. We connect the back side of the left atrial appendage to that line of scar over here, and then finally we get rid of the left atrial appendage. So this is a little bit different, maybe better way to look at this. This is a device that we use during a minimally invasive maze. It's got a very bright light on the tip of it, and it articulates. So this basically takes the place of my finger where I work my way around the back side of your heart. We can do this through a tiny incision. And what we do is we bring that device in, we sneak it around the back side of the heart, we spin the dial, and that light kind of articulates up, comes through the tissue, and then we take that little sleeve that's loaded on top of this, we grasp that and we pull it out through the other incision. Again, we've got 3 incisions, one for the camera port and 2 working ports. And then once we've got that sleeve out, we'll back this device out, and then we'll connect the back end of that sleeve onto the front end of the device that we're going to use to create the line of scar. So I can see the front side, I can use the red rubber catheter to guide the back side until we're safely around the veins, and then we clamp the tissues. When we clamp the tissues, the energy goes from one jaw of the device to the other jaw of the device and creates a line of scar. So that is, we're on the left side here, so in a case like this, we've already done the right side. We'll have a line of scar around both veins, and then this is the clip. Think of a sort of a giant clothespin with Dacron on it, and that will be lowered over the left atrial appendage down to the base of it, and then we will deploy that clip, and that will basically close off the opening to your left atrial appendage. So about 90% of strokes come from the left atrial appendage, and that will get rid of that source of strokes for you. So this is an echo. This is an ultrasound of the heart, but done from inside your body, from your esophagus. So every patient having open heart surgery or minimally invasive maze has a probe down the back of your throat, and this is looking at your heart. So here's your left atrium, here's your left ventricle, there's your mitral valve, and here's your left atrial appendage. So we want to look at this at the beginning of any of these cases, and the day before they do a catheter ablation or the day of a catheter ablation, they look at this to make sure that we're not starting with clot in the left atrial appendage. Obviously, if you had clot in there and we start squeezing on it, that's not going to be a very good thing for you. So we check that at the beginning of the case to make sure there's no clot, and then we check it again at the end. Again, this video stopped playing, but this is left atrium, mitral valve, left ventricle, and now you no longer have a left atrial appendage. So we confirm that in every case that we do for atrial fibrillation. That's what that scar looks like about 90 days after it's been made. So the left atrial appendage is gone, that's completely sealed off. This is what a patient looks like about 3 months after a minimally invasive maze. Obviously no big incision down the middle, and just 3 small incisions on each side. So at the very beginning, I mentioned something called a hybrid approach. And the hybrid approach is something that we didn't develop in Wausau. We went to Vanderbilt to learn about it. But 5 years ago, we started offering patients with persistent atrial fibrillation a hybrid approach. And what this is it's a less invasive way to treat persistent AFib. So paroxysmal AFib is easier to treat than persistent. And persistent AFib requires a much more complete lesion set. And traditionally, the best operation for that had been a full maze. And so what the hybrid procedure, the hybrid approach, is really 2 procedures. It's a minimally invasive maze followed by a catheter ablation. And it basically recreates 90% of a full maze, but without the open heart surgery. So I do a mini maze. You come back a couple of weeks later, we put a little device underneath the skin to monitor your heart rhythm and rate. And then 3 months after that surgical procedure, you come back, and Dr. Rister McKitsy goes up from the groin, looks at all the lines that we've done on the outside, touches those lines up as needed, and then does a flutter line on the right side of the heart. And so we've studied our patients very carefully. We follow everybody with an implantable loop recorder so we don't miss anything. So everybody has continuous monitoring, and the success of this is at least as good as that as a full maze without the big open heart surgery. So to kind of recap a little bit, if you have paroxysmal AFib, the kind of AFib that comes and goes, and medications aren't working for you, then the next step would probably be a catheter ablation. If you have persistent AFib, again, a little bit harder to treat, need a more complete lesion set, catheter ablation can be offered. It's not a wrong thing to do, but it's not going to have the same success rate as it would for paroxysmal AFib. A hybrid approach is going to have a much better, it's 2 procedures, but it's going to have a much better success rate. A full maze is open heart surgery. It's what we would do for persistent AFib if you are already having heart surgery. Again, if you're having other heart surgery, you'd get a full or modified maze. If you've already, conversely, if you've already had heart surgery, there's a lot of scar tissue in there. It would be very difficult to get in there minimally invasively. You would probably be offered a catheter ablation regardless of what kind of AFib you have. A couple of websites. StopAFib.org is a website that was started by a woman who had a minimally invasive maze years ago. She was so impressed by how much better she felt that she literally quit her day job at Oracle and now spends all of her time traveling, giving presentations on AFib, on women's health issues, heart health issues. Importantly, from the standpoint of somebody with AFib, the kind of information that she puts on her website is the latest and best information. She comes to my surgical meetings, she goes to Dr. Riss' electrophysiology meetings, she interviews the thought leaders in the field, and all of that stuff is on her website. So it's pretty much hands down the best overall website for getting information about treatment for AFib. TreatAFib.org is the Aspirus website about AFib. It's a subset of the Heart and Vascular website on the Aspirus, overall Aspirus website. And on that part of the website, you'll find some very specific information about what you could expect in terms of treatment options to be offered at Aspirus. So this is the part where we turn the lights up and take questions. Yeah, in the green.
Could you review what the signs and symptoms typically are for AFib?
Sure. So the question was, can you review the signs and symptoms of atrial fibrillation? So patients often feel their heart racing. They feel palpitations. They might feel lightheaded. They might feel short of breath. They might just not have the kind of energy they normally have. It's interesting because that's not in our slides, and it's not in our slides because when we give AFib talks, everybody in the room has AFib, so we don't use. But for a room of people without AFib, it's a good question. Yeah.
The atrial appendage, does it serve a purpose when you're younger or just becomes a problem child later?
So the question is, what's the purpose of the atrial appendage? The atrial appendage actually does have a purpose. You can get away with getting rid of one of them, but when they started doing these types of surgeries back in the 1980s, they discovered that if you take away both atrial appendages, whether you tie them off, cut them off, clip them off, people get into serious issues with fluid retention. As it turns out, Atrial appendage is very thin and distensible. It's kind of like a balloon, and when your body has a lot of extra fluid on board, it tends to puff up a little bit. It distends, and when it distends, it sends out a chemical signal to your brain. Your brain sends a chemical signal to your kidneys, and you make more urine. So if you get rid of both of these, I remember specifically when I started doing these kinds of procedures back in 2002, we put everybody on just a boatload of diuretic drugs to help you get rid of water, because we thought everybody was going to have fluid retention. As it turns out, it doesn't really happen. It's a very rare instance if you only take one atrial appendage. But yes, it does have a purpose. Yes?
Does AFib give you excessive fatigue?
So the question is, does AFib give you excessive fatigue? And the answer to that is yes. That's one of the symptoms that people can have.
You mentioned age and gender. Are males more prone to getting it than females?
The question is, what's the gender predominance? I know I operate on more males, but I don't know if that's because the incidence is more males.
I think it's just slightly.
So maybe 55% male, 45% female preponderance. Yes?
And then one more on that. Is it predicated on weight and also genetics?
Being overweight has an effect on AFib for a couple of reasons. It's making your heart work harder. Overweight people have a higher incidence of sleep apnea, which definitely has an impact on atrial fibrillation. What was your other question? I'm sorry.
Genetics.
Genetics. You know, there's no gene that's been identified, but there's family cohorts where everybody has AFib. So it's like a lot of things in medicine. We know genes play a role. We haven't quite sorted it out yet. Yes?
About 3 years ago, I was on a tour out west, wound up in the hospital with a pulmonary embolism. And today I went in for my yearly checkup, and my doctor told me that I had had a heart attack, and no one else mentioned it. Did that cause the heart attack, or was that embolism?
So if I got this right, you're wondering if a pulmonary embolism caused a heart attack? No, probably not. That would be unusual. You had both, but those are kind of unrelated issues.
Well, the doctors in Portland told me that I was very lucky to be alive.
Well, you may be very lucky to be alive, but I'm not sure that equates to the PE causing the heart attack.
Because I didn't know anything about the heart attack, and I don't even know if they knew about it.
Yeah, they may not have. Sometimes you get an EKG, and on the tracing, it looks like there's been some scar tissue that's been created. And then we tell the patient, well, looks like you had a heart attack. We don't know when it was. We don't know how your heart function is. We'll move on and get an echo or do a heart cath or something like that. But so sometimes, people have, quote unquote silent heart attacks. They don't know it. We don't know it. And you come in at some point and you get your first EKG in years, and lo and behold, there's the tracing that looks like you've had a heart attack. So that's a fairly frequent thing, actually. Yes?
Does a heart murmur as a child have anything to do with any of these problems as an older person?
So does a heart murmur as a child have anything to do with some of these issues? It can. I mean, if say you have something like scarlet fever, rheumatic fever, and you develop an abnormal mitral valve and your mitral valve leaks and then you develop AFib. But it's pretty unusual. It can happen, but it certainly isn't how most people come by their AFib.
So if you see a regular doctor or nurse practitioner and they say, oh, you have atrial fib, and they start you on medication, when would you see a cardiologist and when would they just handle it themselves?
That's a great question. So if you go to your family practice person, your nurse practitioner, your PA, and they say, oh, you have AFib, you need to be on a blood thinner, or we need to do something up with your heart rate, when and if does that transition to seeing a cardiologist? I think that's a really good question to ask a cardiologist.
Thank you, John. You know, I think if you have a heart-related problem and you're concerned about it, and you want a second opinion with a cardiologist, that, you know, this is still, I believe, the United States, so, you know, you ought to be able to do that. And most of your practitioners don't mind if you ask for that, or if you're worried about it, or you're not reassured by what they said, or whatever. You know, the approach to AFib is generally, as Dr. Jankowski already said, we have to take care of the concern about stroke. So yes, almost everybody needs to be on a blood thinner, unless you're you know, quite a bit younger and don't have any risk factors. So you need to be on a blood thinner. Your heart, we don't want your heart going too fast for too long because it can wear out. So if you're, you know, happy as a clam and you didn't know you had AFib and you're able to do what you want, you can walk upstairs and you're not suddenly short of breath and all that sort of thing, then probably that's fine. But if you're having problems with exertion, if the palpitations that come and go bother you a lot, then that's not a bad time to see a cardiologist. When you first come down with AFib, if you are totally unaware of it, but you also show up with heart failure symptoms, new swelling in the legs or weight gain, inability to lie flat at night when you go to sleep, excuse me, because of shortness of breath, you know, you walk up that hill that you've walked up for, you know, 5 years on your daily walk, and suddenly you're short of breath. All of those things might suggest that besides the heart rate, you need to have some evaluation of your heart to make certain that you haven't developed valve disease, that you haven't developed a myopathy or a problem with the pumping of the heart. So, you know, I think if you're concerned or if your symptoms aren't resolved by what your practitioners have done, then that's probably a very good time to see a cardiologist. And most of the time, your practitioners don't care that you go and seek other help. Yes, ma'am.
What about, you hear so much about people that don't have heart disease or heart problems should take a baby aspirin a day.
So the question is, when and why should you take a baby aspirin even if you don't have any obvious heart problems? There were some studies done in the late 90s and in the early 2000 years. One was the nurses, I think it was called the Nurses Health Study, and another, there was one that was done for men too. And what was found is that a baby aspirin, 81 milligrams a day, reduced the rate of heart attack and in stroke in people who had no prior history of either. So, so that's where that idea of taking a baby aspirin comes from. A baby aspirin, if you're known to have AFib, is not enough treatment, especially if you're 60 years old or longer, especially if the AFib is lasting for any length of time. So I want to dispel the idea that many people have that aspirin is just another blood thinner and it's equivalent to Coumadin. It is not. It is not as good as Coumadin. It is not as good as Xarelto and Eliquis and Pradaxa, the drugs that the newer drugs that you see on TV. Those are much more specific for AFib. But an aspirin does reduce somewhat the risk of stroke in asymptomatic people who have not prior had a history, and reduces the risk of coronary disease. Aspirin is more specific for coronary artery disease, so it is a very good thing to take for most folks in their 60s and older. Yes, ma'am? Yeah.
Some of these medications, other than warfarin, they tell you some of the side effects, and it's almost scarier than the disease. How often does all the things happen?
Well, I think what you need to know is that when a drug study is done, anything that anybody taking that drug experiences could be a side effect. So they list all of them. So if somebody got a cold, but didn't know it was a cold, maybe a slight cold, and got a stuffy nose or pharyngitis, it's a scratchy throat, and the drug study, that would be a possible side effect, because we never really identify when you get a cold what virus it was, or if it was a virus, or if it was bronchitis, or whatever. So you can imagine that's why there's always a laundry list, and it sounds about the same for any drug you look up in the Merck manual. So what you have to know is, what are the things that appear to occur more likely than just chance alone? And yes, people on blood thinners, if they fall and hit their head, that's bad, because there's a certain fraction of them that are going to bleed into their head. And there's people who can bleed from GI problems, ulcers, or what are called AV malformations in the colon. But sometimes, actually, when people bleed from their colon or their stomach, or their bladder, you actually find they've got a bladder tumor. They've already got something abnormal there. So that way, it could actually be a sentinel event, something that's really helpful to someone. I'm not saying it's a good reason to go on a blood thinner. I'm just saying that not every bleeding episode is bad if you find that colon tumor or whatever. The bottom line is risks versus benefits for these drugs. The problem in the United States is not that too many people take blood thinners. The problem is that not enough people get put on blood thinners because they're scared of them, or they talk their doctor out of it, or they say they'd rather not do it, or they find them, some of the new ones obviously very expensive, and Coumadin is, can be a trial. You got to keep getting your blood drawn and all that. So a lot of people, they've done a lot of studies, 3 or 4 years out, they're off their blood thinners, even though their main problem, AFib or whatever, or maybe recurrent pulmonary emboli, are still things they should be treating themselves for. Yes, when people have to, the advertisements have to put the little blue line and and possible liver problems at the bottom. They have to put that in there, but the bottom line is risks versus benefits. If you've got a very high risk of stroke and a not very high risk of bleeding from the drug, then you should be on the drug. I mean, it's just math.
Thank you.
You're welcome. Yes, ma'am.
I understand that there's cardiologists who are basically plumbers and ones that are electricians. Now, the AFib, is that also, or what's the commonality between that and like SVT and an ablation for that?
Oh, that's a good question. So the question was, what's the relationship between rhythm problems called SVT, or supraventricular tachycardia, meaning involved with the chambers above the major pumping chambers, above the ventricles, that's SVT. And what's the relationship between that and electrophysiologists and atrial fibrillation? Well, the supraventricular tachycardias, so in one way, atrial fibrillation is one of those, because the atrium can go very fast and make the ventricles go very fast, but irregular. Many other types of SVT, one would be atrial flutter, which I already showed you an example of. Like I said, 95% cure with a catheter-based ablation. You can also have atrial tachycardias. I showed you an example of that up there, with a little spot that just decides to fire one day and drive you crazy for some reason. And those all tend to be very easy to ablate because they're very small, specific places. And then the most typical one that we see in the older population is AV nodal reentry. So the connector between the upper and lower chambers can get 2 pathways in it. It can develop a second one, so the electricity can circulate around that AV node like a dog chasing its tail. And if you have to close off one of those. But again, those sorts of ablations we're highly successful at, after it's been developed over the last 20 years. Because it's very specific anatomical spots that we need to look at and ablate, and we often only have to put in a very finite number of ablations, maybe 5, and boom, it's gone and it's not coming back. AFib, as I said, is an example of a problem that tends to be progressive, but we can wall off, the troublemakers much of the time and reduce the likelihood of that coming back. But we have to do a lot more ablations, either distance-wise or in terms of the tools that Dr. Jankowski uses, or specific spots, in my case, where I'm sort of building a stake fence around the garden. I don't know if that explains it. Oh, yes, in the back, ma'am.
When you're on a warfarin and whatnot, you have to go and have your blood tested and whatnot. If you're on Xarelto or Eliquis, how do you know whether it's even working?
Well, that's a great question. So the question was, with warfarin, or Coumadin, as it's also called, you have to go in and get your blood tested. Maybe to begin with, you get it tested twice the first week, and then every 2 weeks, and eventually once a month or something like that. So how about these other blood thinners? What blood tests do you need to do for them? Well, I thought it was always kind of paradoxical. They're very strong agents, but almost everybody, no matter what your size is, you're on the same dose, and you don't need to get your blood tested. So it's kind of a miracle that no pharmacologic rep has ever been able to explain to me how we can get away using the same dose of drug on the entire population and not have to test for it. Now, there are a few tests, obviously, in the research for these drugs. There are some tests. They're very difficult to do. They're very expensive. They're not available, in any hospital but a research hospital. And so, for some reason, they've been able to find a dose of drugs that works equal to or better than Coumadin and is almost always the same dose for everybody. Maybe you change things a little bit for age, you change things a little bit for body size, you change things a little bit for kidney function. But yeah, it's kind of a paradox. You don't need to get your blood tested. It's just not necessary. Which is, a great advantage to many people if you have bad veins, if you can't hop in the car every 2 weeks or whenever, you eat too many rutabagas and whatever. Oh, yes, ma'am.
Some of these TV ads say that these newer drugs target only one thing for AFib, where warfarin targets several. Now, how does that play out?
Well, so the clotting cascade, they're talking about all the different proteins and other things that have to sort of line up in 3 different branches to form a blood clot. So blood clots are formed by, white clot is these platelets, and then there's fibrin, and there's 2 pathways for the fibrin and 1 thing for the platelets. Aspirin tends to help reduce the clotting ability of platelets. So Coumadin affects, as you said, 5 or 6 things in this pathway. It's a nightmare to learn those pathways, especially the night before the test. You have no hope. You're going to be able to learn 5. There's no way you're going to learn all 10. Okay. Now there's something called factor 10. And that's in this cascade, and that's the thing that most of these newer blood thinners help change or regulate to reduce the likelihood of clotting. So that's probably how they're able to use just a single dose for most people. So yes, Coumadin hits a lot more spots. They all move at different rates as you take the drug. It doesn't build up to where it's going to be for a couple of days, and when you stop it, it doesn't go away for a couple of days. The newer drugs start within an hour or 2. They're a maximal activity within an hour or 2, so they turn on very quickly. There are some drugs, some antidotes for those drugs that turn them off pretty quickly also, but they're not. I don't think they're quite available yet. The Pradaxa is the one where it's been out for a while. The other 2 drugs, I think it's just been released or okay by the FDA, but I don't even know if it's available in the hospital yet. So I don't know if that answers your question, but to answer the test, it's much easier with those 3 new drugs as to what it affects, because it only affects one thing. Yes, ma'am.
Okay, well then, if you can turn off Coumadin or warfarin easier with vitamin K or something.
Well, yes, you can turn it off, and effectively, we're actually very comfortable with that. You can get a vitamin K injection, and you can get what's called fresh frozen plasma. And that will add back some of those factors that Coumadin has gotten in the way of the body from generating, so that you can kind of normalize your clotting system, not instantly, but in a couple of hours.
But then, if you were in a serious accident, how would you turn off these newer drugs? Turn them
Well,
off that quickly?
Actually, with the antidotes, you can turn it off more quickly. But as I said, the antidote for the Eliquis and the Xarelto, thank you, they've just been, I think, okayed. But the one for Pradaxa is out there. So you can actually turn them off quicker. But that's relatively recent. Now, to answer the question, and we were very worried about this too, but when these first came out, you said, well, what if somebody has an accident? I mean, that's terrible. Well, there's a couple of things. There are some substances that the drug companies haven't spent a lot of time investigating, but other people have, that are in the hospital that can be given, that are not fresh frozen plasma, but there's other sort of substances that can sort of replenish your clotting system. But the way the studies were done that compared Coumadin to these other drugs was that there were people on Coumadin and there were people on these drugs. And there was just as many car accidents in one as in the other. And there was just as many this as that in the other. That's the whole idea of a randomized study. So I can't tell you if everybody that had a car accident on the new drugs went downhill. But if they did, it was balanced out by the fact that maybe there were fewer strokes or other events in the people that took the newer drugs. So on balance, the two approaches are pretty similar in safety. They're not, neither of these things are safe. Remember, we have to balance it against the risk of a stroke.
Thank you.
You're welcome. In the back?
I have a question about terminology that's been used tonight. And that is, I picked up on it in context, I believe, but your use of the word ablate and ablation, what's the synonym for that? I know we're right back to the basics, but ablate and ablation were new terms for me.
Okay, well, I guess we should have discussed that. So, so the question is ablate and ablation, and what does that mean? Really, that just means getting rid of tissue that in the heart that you think you don't want to have there. So it's destruction either of some function of that tissue. It doesn't mean it structurally goes away, but its electrical activity can no longer be maintained. So in the case of an RF ablation, radio frequency, which works by heating, essentially you dry the tissue out by heating it up to, maybe 50 degrees centigrade. So 37 is your body temperature, 100 is boiling, so you're heating up to about a third of the way to boiling. Now with the cryoablation, we're cooling the tissue to -45, -50 degrees centigrade. So we're freezing it solid for a couple of minutes. And so that's how we destroy the ability of that to work.
Maybe a different way to think of that. I'm not sure that ablation is probably the best term we could have used, but it was maybe picked up because if you told people you were going to scar their heart, they might never come back. But basically what we're trying to do, like Dr. Riss says, we're trying to either dry out or freeze the tissue so it can no longer conduct an electrical impulse. And we're doing this in a pattern. We're actually creating lines. And so to get a good ablation, you have to have a line that completely separates. So when we call this, the term we didn't maybe use a lot tonight was pulmonary vein isolation. So we are isolating your veins from your heart. The rhythms start in the veins. We can't necessarily get rid of that little cell that's causing the problem, but we can basically isolate or insulate it from your heart. So if you think about you know, the pair of pliers in the toolbox with the plastic on them, with the rubber, the yellow or red or whatever color you got in your particular toolbox. That's to prevent you from getting a shock if you catch a live wire while you're working on a fuse box or something. So we're isolating or insulating your heart from the veins. We're separating it. And we call it ablation because it's I guess it's kind of a euphemism for ablating tissue. We call it ablating. What we're really trying to do is create a line of scar. And I hope that helps. I don't know. Yeah.
So with the rhythm, the electrical rhythm is kind of running all over like a road map, and you were showing it running all over, and then by doing that, are you trying to create a clear path for the electrical rhythm to go, where you want it to be and not to be?
Yeah, so the way to think about this, I think, you know, people often ask, you know, is the MAZE, is that an acronym? Does it stand for something? It's actually called a MAZE. So Dr. James Cox was the guy who invented this procedure back in the 1980s at WashU down in St. Louis. And in the original, in the early procedures, they did something called a corridor procedure, where you remember in the very first slides where I showed you the SA node at the top and the AV node in the middle of the heart. And they said, boy, if we could just get the energy from here to here, they wouldn't have atrial fibrillation and they'd be back in rhythm. And that's true, but what it would do if you just basically put a line, put just bumper guards down both sides of that thing, you wouldn't have an electrical impulse reaching the rest of the tissue. And you want your atrium to contract. You want it to squeeze, because otherwise it's just another big left atrial appendage, and you're going to be a massive setup for a stroke. So they call it a MAZE procedure because what he did was he drew the whole thing out and he says, you know, if I create this line of scar here and this line of scar over here, we'll give that energy away to get to every part of the atrium. We won't give it enough room to walk around in cycles, and so we'll activate all the atrium, but we won't be able to have atrial fibrillation. And that's how the MAZE procedure was born. So it's like a mouse in a maze. You can only get from point A to point B in one way, but along the way, those electrical impulses have a way to activate all the tissue and get your heart, get your atrium to contract again. Okay? Right here.
If you have someone with high keloid tendencies and you do this type of surgery, how does that affect it?
So that's a great question. So the question was, if you have somebody, you know, some people when they have surgery, they form a keloid. And a keloid is a bumpy scar that's sometimes pretty painful, and there's ways to treat that. And some people they're just keloid formers. Every time they have a surgery, they get this funny looking bumpy scar. And so the question was, if we did this, if we burned the heart tissue in somebody who's a keloid former, what would that look like? And the quick answer is I don't have a way to know that specifically because we don't go back and look at this tissue. But I think one thing that's important to think about is when we do surgery and we sew that tissue back up, that is a very specific cell type that forms that keloid. And you don't have that kind of cell type in your heart. Your heart is all muscle. And so I don't think that you would get, I've never even thought about this, so it's a great question, but I don't think that you should never, I wouldn't say to somebody, boy, if you're a keloid former, you shouldn't have this done, because we operate on lots of people. Well, it's a good, I guess I do sort of have an answer. We operate on plenty of people who make keloid, and they don't have a higher graft, they don't have a higher rate of having their vein grafts fail, they don't cause abnormal scar tissue around the blood vessels, because those are two very different kinds of cell types. The kind of cell type that causes keloids doesn't exist on your heart. Okay? Yeah?
Would a person with polycythemia vera have a greater chance of having these conditions of the heart?
So the question is,
Because of the
would a person with polycythemia vera have a higher incidence of having atrial fibrillation?
anything like that?
I'd say the answer is no to that. I know there were some back there, way in the back in the blue.
If you're scheduled for regular surgery, for other surgery, and you have to go off of your blood thinner for 3-4 days, is that dangerous?
So the question is, say you're having elective surgery and you're on a blood thinner, say Coumadin, And so they ask you to stop your blood thinner as kind of a preparatory step to having the surgery. Are you at increased risk of having a stroke? And the answer to that is yes. The solution to that, and it's not always done, it's sometimes done, and I think it's kind of an individualized decision, is we have a procedure called bridging. So you stop your Coumadin or your warfarin 5 days before, and then the last 2 or 3 days before the surgery, you do Lovenox injections at home. So Lovenox is a blood thinner that you can inject into your abdomen at home. We don't typically bridge our patients. Well, I should say I don't typically bridge my patients unless they've already had a stroke or some other event that would make me more worried about that. And we do that echo, that special echo at the beginning of every procedure. And I could count on one hand the number of cases I've had to cancel over the last 12, 13 years of doing this. And we routinely hold Coumadin and we don't see clot there 5 days later. So I know that some Coumadin clinics will routinely, I don't know what the Coumadin clinic Aspirus does.
Mostly for mitral valve.
Okay, so they don't routinely bridge unless you've got some very specific diagnoses. So good question. Yes.
I was just wondering if unrelated surgery can cause AFib.
I think the question was, how can unrelated surgery cause AFib? Oh, can it?
Unrelated surgery causing AFib.
Well, you know, people can have AFib around any surgery. So for instance, when we do heart surgery, about 1/3 of our patients have AFib after surgery, even when they've never had AFib before. If you're in the hospital and your body's stressed and say your potassium level gets kind of low or your magnesium level gets kind of low, that can cause AFib. We would generally think of those as kind of limited AFib. In other words, if I see somebody and they've had one episode of AFib and they've never had any other AFib, and I can clearly relate it to, say they had diarrhea and their electrolytes got all off and they came in with AFib, I don't necessarily think I would treat them like I would anybody else with AFib. But you have to be careful with that because you say, well, were they just waiting to have AFib and that unmasked it? Or, so it can, but it's probably not super common in non-heart surgery patients. Other questions? All right, I'm gonna have Sabrina, she's our AFib clinic nurse, come up and tell you guys a little bit about how you might see one of us if you want to.
My name is Sabrina and I'm the nurse in the AFib clinic with these guys. If any of you have any further questions, concerns, have somebody that maybe wants to be seen, I have a card outside the doors. There's a table and my card is there with my phone number. Feel free to give me a call or come and see me at the end, and I can help sort things out or just give you additional information if that's what you want. Thank you all for coming out.